Hello everyone, this is Kamran Bhopal and I'm here to discuss the questions of small renal mass outpatient scenario usually asked in the ST3 urology training interviews. I've already discussed the history, so you can go back and look at my video which explains the history of small renal mass. I'm going to discuss a few different questions which may be asked and you should be aware of. I did not mention the investigations in my history station, so if they ask you what investigations would you perform in this patient, then you can say I would request a full blood count, use an ESR, calcium and liver function tests, a CT triple phase. So CT triple phase is important. So CT triple phase is the one that you do for renal masses and to characterize renal masses. So CT triple phase scan for characterization of renal mass, and then a CT chest as staging scan. The important thing to mention is you usually are reading through these things, but you don't really differentiate why we do what. You know, what is CT triple phase, what is a trauma spiral CT, what is a CT urogram and excretory phase. So I can actually do a separate video on that, but a CT triple phase has got three phases. One of the phase is a non-contrast phase, so there's no contrast looking at the lesion. Then it has got an arterial phase and a nephrogenic phase, which is a portovenous phase. And basically this is all related to the contrast enhancement of the renal lesion to look at the vascularity and the consistency of the lesion. So blood CT triple phase and a CT chest as a part of staging scans, and then you can mention I will then discuss it in the renal MDT or my supervising consultant and make a plan moving on from there, give the patient some information leaflets. So on a CT, so they say, okay, what are you going to look on a CT? So number one, we have to look at the size and the site of the tumor. We'll have to look at the contrast enhancement. So if there's a 5 Hounsfield unit rise or more, that is significant. Then extension of that tumor, such as extrarenal spread into the lymph nodes, renal vein involvement, IVC involvement. Also, we have to look for involvement of the contralateral kidney, because obviously if you're planning to take one kidney out, and then we have to make sure that the other kidney is healthy, the cortical thickness is good. So looking at the contralateral kidney. And lastly, anatomy for surgical planning about how you're going to approach this patient. So if you say these 5 or 6 things, they would understand that you know what you're looking for in a CT. What are the indications of renal biopsy? So, you know, most of people say it's a controversial topic, but with new treatments, actually, it's not that much of a controversial thing anymore. But, you know, renal biopsy is not always done because the histological, we're actually looking at what histological answer we're getting with that small biopsy needle with some cells coming out. So the indications would be number one for active surveillance. You know, if the cells are cancerous or they're looking normal, okay, fine. If we're thinking this is benign, let's do a biopsy. Usually renal mass is less than 3 centimeter. About, I think 20% of them are benign, and that's why we do a biopsy, just to see there's no cancerous cells, so we can do active surveillance. Then if the CT scan is indeterminate and we're not quite sure, then we can consider it, whether, you know, thinking whether this is a lymphoma, is this metastatic disease, is something else. And then we can consider it in ablative treatment, prior to ablative treatment or cryotherapy, or, you know, the newer treatments that are coming in. And lastly, we can use it for systemic treatment. So we take the sample, we see what type of cells or cancer this is and what type of systemic chemotherapy we can give, usually in, you know, patients who are not medically fit for cytoreductive surgery, and we just need to, or even if they're fit for cytoreductive surgery, we want to give them adjuvant chemotherapy or chemotherapy before we actually take them to the theater for that. So these are a few things: a small mass less than 3 centimeter, active surveillance, indeterminate CT scan, ablative or and consideration for systemic treatment. So questions about stages of renal cancer. So there's 4 stages, so T1, T2, T3, T4. You don't have to say specifically 1A, 1B, 2A, 2B, 3A, B, C. I'm going to say it just so that you're aware, but as far as you say the initial bit, that is okay. So if it is confined to the kidney and is less than 7 centimeter, it is T1. T2 is confined to kidney and greater than 7 centimeter. Stage 3 is extrarenal spread, and stage 4 is beyond the Gerota's fascia and adrenal gland involvement. So I'm going to tell you specifics now. So T1, confined to kidney less than centimeter, you've got 1A and 1B. 1A is between 1 and 4 centimeters, 1B is between 4 and 7 centimeters. Then T2, which was greater than 7 centimeters within the kidney, if it is between 7 and 10, that is 2A. If it is greater than 10, this is 2B. Then you've got extrarenal spread in T3. You've got T3A, T3B, and T3C. So T3A is basically involvement of renal vein. T3B is involvement of inferior vena cava below the diaphragm, and T3C is involvement of inferior vena cava above the diaphragm. So that's how you differentiate, but no one's going to ask you that. Then we've got T4, and T4 means beyond gyrus fascia and adrenal gland, which we know about. Okay, so the next question that they may ask is about DMSA scan. So what is a DMSA scan? So DMSA scan, this is a tracer, the DMSA, and it's taken up by the kidney. And the more the tracer is picked up by the kidney means that much of renal function is present in this kidney. This is usually used to differentiate between the function of one kidney from the other. So it doesn't matter what the EGFR is. If it's like EGFR of 30, the total renal function is that 30 EGFR is 100% of the person's renal function. And then the two kidneys can be compared, saying that, okay, 60% of the function is coming from the right kidney and 40% is coming from the left kidney. Whether the EGFR is 30 or 60, that doesn't matter in DMSA scans. But it does matter if the EGFR is generally low, then you have to do a DMSA scan, because consider if someone's got an EGFR of 30 and the left kidney has got 80% of the function and this right kidney has got 20% of function, and this kidney has the cancer, and you remove the kidney. So this good functioning kidney, as I said, had 80% of the function. So we remove the kidney, we've left 20% of that function, and the patient's EGFR was already 530. So the patient's going to go on dialysis because this kidney was already not functioning. So that's why DMSA is important before we do any type of renal surgery, or if we don't always do it if the EGFR is very good. So EGFR is 90 and you think on the CT you can see that the cortical thickness of the kidney is very good, then you may not consider doing a DMSA. But anything, if EGFR is in the 50s and you're thinking, oh, the cortex is a bit thin, we always have to do a DMSA scan to see what is the split function of the two kidneys, because our treatment options might actually change. So, if I've got 50-50 function with the EGFR of 90 and the patient's on blood thinners, for example, I might go for a nephrectomy, take out the whole kidney, even if it's a relatively smaller mass, because I know that the kidney is functioning pretty good. But if the EGFR is 50 and that's actually a good functioning kidney and it's a reasonably small mass, I might do a partial nephrectomy or nephron sparing surgery and try to preserve as much of the kidney as possible. And the reason I would do that is because this is a good functioning kidney, and take the risk even on a patient on blood thinners of bleeding, because you're literally cutting through the kidney, and it's got a very high risk of bleeding as compared to a complete nephrectomy in which you just clamp and just cut the kidney off. So DMSA is very important. Anyway, we've gone a lot in detail of DMSA. So they may actually ask you what are your treatment options and give you DMSA scans. One DMSA scan gives 90% and 10%. What are your options? One 60% and 40%. What are your options? So different surgical options are, active surveillance. You've got surgical treatment such as partial nephrectomy, radical nephrectomy, minimal invasive procedures such as radiofrequency ablation and cryotherapy. Moving on, they might ask you about consent for nephrectomy. So you have to tell them what you do in consent. Then there's a common question they ask if you're doing really well in the interview and you're in the last few stages. They say, okay, what benign renal lesions you know about? So the commonest benign lesion is oncocytoma. Then you got angiomyolipoma. Then some renal cysts and renal abscesses, fibromas, lipomas, adenomas. These all are benign lesions. The commonest one, always remember, cytoma is the commonest, and then angiomyolipoma. Then Bosniak classification of cysts, you need to know that there's 5 different classification of cysts, which is Bosniak 1, Bosniak 2, Bosniak 2F, Bosniak 3, and Bosniak 4. I'm not going to go in details about, the septations, calcifications, contrast enhancement, water attenuation. These are the things that differentiate it, and you can make your own definition how, these septas, calcification, and contrast enhancement differentiate what cyst from what cyst. But the important thing to then remember is, after you made that definition yourself, that 2F cysts have 5% malignant potential. Type 3 cysts, which have contrast enhancement, have got 50% chance of malignant potential, and you can do active surveillance versus radical treatment. And type 4 who have contrast enhancement and also have soft tissue components are about 95% malignant. So almost anyone who's fit should have some sort of surgery done to get that removed, because it's almost 95 to 100% malignant. So yeah, renal cysts, read them up. It's not that difficult to learn. I don't expect them to ask you exactly, but as far as the septations, calcification, contrast enhancement, what is water attenuation, soft tissue components, stuff like that. So these are the things that differentiate different level of cysts, and the radiologists are quite good at doing that. But we should be aware of Bosniak classification of renal cysts. If you're doing really good, then they may ask you, what do you know about oncocytoma and angiomyolipoma? So oncocytoma is a slow-growing tumor with a genetic inheritance component, and the commonest solid benign tumors. 5% of all primary renal neoplasms, male predominance of 2:1, and usually occurs in the 7th decade of life. The diagnosis is histological, since renal biopsy is quite unreliable. That's where I was talking about the renal biopsy. So you cannot differentiate an oncocytoma with eosinophilic variant of renal cell carcinoma on a renal biopsy, and henceforth you need histological diagnosis by actually removing it, and then you come to know that this is actually an oncocytoma. And you would be thinking, okay, fine, so how would we then know on histology this is an eosinophilic variant of RCC or this is oncocytoma? So it's an easy answer. I don't think they're ever going to ask this, but the oncocytoma is coming from the DCT and the collecting duct, so distal convoluted tubule and the collecting ducts, whereas this eosinophilic variant of RCC would be coming from the proximal tubule. So that's the difference. Then they can ask about angiomyolipomas. You've got two types, sporadic and associated with tuberous sclerosis. Sporadic is about 80% prevalence, whereas with tuberous sclerosis, 20% prevalence. Sporadic is 4:1 female predominance. Middle-aged ladies, 80% is right-sided with the growth rate of 5%. Then with the tuberous sclerosis one, it is 2:1 female predominance, and mean presentation is about 30 years, and growth rate is about 20% every year. The imaging for angiomyolipoma, on radiological investigations, you see fatty lesions with density less than 10 Hounsfield units. They can be lipid rich or lipid poor. So if they're lipid rich, it's a good sign. If they're lipid poor and vascular rich, then that's a bad sign, because they can bleed. There's a syndrome called the Wunderlich syndrome, which is spontaneous acute hemorrhage of an angiomyolipoma. Usually occurs in angiomyolipomas with higher vascular component. And the risk factors include, symptomatic patients who've got AML, women of childbearing age, and lipid poor AMLs. So how would you manage AMLs? If AML is less than 4 centimeter and the patient is asymptomatic, you can do yearly surveys with ultrasounds, and you can discharge after 3 years. If AML is greater than 4 centimeter or symptomatic at diagnosis with any size, you can consider selective embolization, partial nephrectomy, or a simple nephrectomy. So I don't think they're going to go into this much detail, but it's good to be aware of this. And I think I've discussed some of the important points which will help you in your ST3 interviews. So I hope you've gained from it, learned from it, and I'd love to hear feedback from you on what else you would want to know. All the best, take care, and I'll see you next time.